If you inadvertently seal over caries, what happens? Arrested caries. If you feed a person through a tube, then you decrease the risk of caries. That is true. You have a 40-year-old patient with all 32 teeth, no cavities, has stain and catch in pit of molar. What do? Watch and observe, sealant, or composite. I'm not sure, but I think the question is watch and observe because there is no cavities. Question: enamel caries best detected by explorer catch. True. Diagnosis of pit and fissure caries by explorer catch. Conical shaped caries with broad base with apex towards the pulp is commonly seen in smooth surface caries. Question: dentino-enamel junction. It's different between smooth caries, where it's conical, and occlusal, where the apex is at occlusal. Interproximal, the apex is at dentino-enamel junction. This is true. Caries in children depends most on amount, consistency, and time. All of them. Occlusal caries, where is the base of the cone? Occlusal caries, where is the base of the cone? A triangle base towards the dentino-enamel junction and apex towards the tooth surface. Yes. Question: which of the following is a factor for smooth caries and sugar intake? Which of the following is a factor for smooth caries and sugar intake? Consistency. Consistency because it's the sticky type. It stays on the tooth longer, allowing bacteria to keep pH lower for longer. This is regarding the factor for smooth caries and sugar intake. Question: what caries lesion has V shape pointing to the pulp? Smooth caries or smooth surface. Smooth surface caries most likely due to plaque. Smooth interproximal surfaces. Fluoride works best on smooth interproximal surfaces. Next question: what kind of dentin should not be restored? Answer is sclerotic dentin or evernated. Evernated. Let's look for the pronunciation of that word. Evernated.
Hibernation or eburnation.
Hibernation.
Hibernation or eburnation.
So hibernation or hibernation. Next question. Treatment for root surface caries. Glass ionomer composite. Treatment for root caries. Next question. Mechanism of caries indicator. It enters the dentin and binds to the denatured collagen. The Explanation is a colored dye in an organic base adheres to the denatured collagen, which distinguishes between infected dentin and affected dentin. Next question. What type of caries detection is the Gold4 used for? What kind of question? What type of caries detection is the Gold4 used for? Let's see, Gold4. Gold4 is so Gold4 Gold4 is an instrument that is a diagnostic imaging instrument. That uses light to detect early coronal tooth decay. And that is at day 40. Okay. So it's used for all caries. Okay. Question. Diagnodent is used to detect class 1 cavities. Diagnodent. What it does is, you can see the image here. Coherent beam, light comes in, and then it absorbs it again. The reflection of the fluorescent light. Diagnodent. How it works. Diagnodent measures laser fluorescence with the tooth structure. As the incident laser light is propagated into the site, two-way handpiece optics allows the unit to simultaneously quantify the reflected laser light energy at the specific wavelength that the device operates, which is 60 to 55 nanometers. Clean, healthy tooth structure exhibits little or no fluorescence, resulting in very low scale readings on the display. However, caries tooth structure will exhibit fluorescence proportionate to the degree of the caries, resulting in elevated scale readings on the display. The device is designed as an adjunct to a traditional oral examination in the detection of oral occlusal decay. Teeth that are suspicious for caries are ideal candidates for surveying with the device. So there's diagnodent. Diagnodent according to what it says here, according to this, is better used in us. Better outcomes. Let's see. Tradition. So, diagnodent. So talking about diagnodent, the examination of teeth and restorations, the clinical examination of caries traditionally has been diagnosed by one of the following: by visual changes in tooth surface, texture, color, tactile sensations when an explorer is used judiciously, radiographs, transillumination. However, over the past decade, several technologies have emerged that show promising results for the clinical diagnosis of caries: diagnodent, digital imaging fiber optic transillumination called DFODI, quantitative light induced fluorescence QLF, and electronic caries monitor. Because no test now available is completely accurate, the dentist cannot rely solely on one test to make a decision whether to treat surgically or chemically. Caries is most prevalent in the faulty pits and fissures of the occlusal surfaces where the developmental lobes of the posterior teeth fail to coalesce, partially or completely. It is important to remember the distinction between primary occlusal grooves and fossa and the occlusal fissures and pits. Primary occlusal grooves, fossa, are smooth valley saucer landmarks indicating the region of complete coalescence of developmental lobes. Normally, such grooves or fossa are not susceptible to caries because they are not niches for plaque and furthermore are frequently cleansed by the rubbing action of food during mastication. Conversely, occlusal fissure and pits are deep, tight crevasses and holes in enamel where the lobes fail to coalesce partially or completely. Fissures and pits are detected visually. Use of an explorative diagnosing fissure caries is strongly discouraged because injudicious use of an explorer may in fact cause fracture of the surface enamel that has been weakened by the caries destruction beneath it. An occlusal surface is examined visually and radiographically. The visual examination is conducted in a dry, well-illuminated field. Thorough direct vision and reflecting light through the occlusal surface of the tooth. The occlusal surface is diagnosed as diseased if there is chalkiness or apparent softening cavitation of tooth structure forming the pit or fissure, or brown-gray discoloration radiating peripherally from the fissure or pit. Radiographic diagnosis should be made from a wide-angle radiograph when radiolucency is apparent beneath the occlusal enamel surface emanating from the dental enamel junction. In contrast, a non-diseased occlusal surface will have either grooves or fossa that have shallow, tight fissures that exhibit superficial staining with no radiographic evidence of caries. The superficial staining is extrinsic and occurs over several years of oral exposure in a person with low caries risk. Precarious or carious pits are occasionally present on cusp tips. Typically, these are the results of developmental enamel defects. Carious pits and fissures occur on the occlusal 2/3 of the facial or lingual surface of the posterior teeth and on the lingual surface of maxillary incisors. Proximal surface caries. One form of smooth surface caries is usually diagnosed radiographically. However, it also may be detected by careful visual examination, either following tooth separation or through fiber optic transillumination. Brown spots on intact hard proximal surface enamel adjacent to and usually gingival to the contact area are often seen in older patients whose caries activity is low. These discolored areas are a result of extrinsic staining during earlier caries demineralization episodes, each followed by a remineralization episode. Such a spot is no longer carious and is, in fact, usually more resistant to caries as a result of fluorohydroxyapatite formation. Restorative treatment is not indicated. These arrested lesions sometimes challenge the diagnosis because of faint radiographic evidence of the remineralized lesion. Proximal surface caries in anterior teeth may be identified by radiographic examination, visual inspection, in which transillumination is optional, and or probing with an explorer. Smooth surface caries occur on the facial and lingual surfaces of the teeth, particularly in gingival areas that are less accessible for cleaning. The earliest clinical evidence of incipient caries on these surfaces is a white spot that is visually different from the adjacent translucent enamel and will partially or totally disappear from vision by wetting. Drying again will cause it to reappear. This disappearing and reappearing phenomenon distinguishes the smooth surface incipient caries lesion from the white spot resulting from non-hereditary enamel hypocalcification. Both types of white spots are undetectable tactilely because the surface is intact, smooth, and hard. For the carious white spot, preventive treatment should be instituted to promote remineralization of the lesion. Preventive treatment, The presence of several facial or lingual smooth surface caries lesions within a patient's dentition suggests a high caries rate. In a caries susceptible patient, the gingival third of the facial surface of maxillary posterior teeth and the gingival third of the facial and lingual surfaces of the mandibular posterior teeth should be evaluated carefully because the teeth are at the greatest risk for caries. Again, in a caries susceptible patient, the gingival third of the facial surfaces of maxillary posterior teeth and the gingival third of the facial and lingual surfaces of the mandibular posterior teeth should be evaluated carefully because the teeth are at great risk for caries. Advanced smooth surface caries will exhibit discoloration and remineralization and will feel soft to penetration by the explorer. The discoloration can range from white to dark brown, with rapidly progressing caries usually being light in color. With slowly progressing caries in a patient with low caries activity, darkening occurs over time of extrinsic staining and remineralization of the calcified tooth structure occasionally may harden the lesion. such as arrested lesion may at times be rough, although cleanable, and restoration is not indicated except for aesthetics. The dentin in an arrested remineralized lesion is termed eburnated or sclerotic. So we have figure 2.3 in the operative PDF of operative dentistry. I think it's Mosby. Yeah, Mosby's review. Figure 2.3. The caries can be diagnosed clinically by careful inspection. A caries pit on cusp tip, a loss of translucency and changing color of occlusal enamel, resulting from caries fissure, white chalky appearance on shadow under marginal ridge. Okay. Incipient smooth surface caries lesion or a white spot has intact surface. And smooth surface caries can appear white or dark, depending on the degree of extrinsic staining. Okay, so again, caries pit. Okay. Restorations can be diagnosed clinically as being defected by observing the following: significant marginal ditching, significant improper contour, recurrent caries, aesthetically displeasing dark staining. Now, an extensively restored teeth with weakened and fractured cusps. Note the distal development fissure in the second molar, which further predisposes the distal cusp to fracture. So, diagonal dent. That was looking for diagonal dent. So remember, diagonal dent will be helpful for diagnosis of caries, pit, and fissures. Why? Because it reads the fluorescency of the damaged dentin. Next question. So you're having in your office a observation, number of people with caries or other stat that you're looking for in your office this year is 300 out of 1,000. Last year it was 200. So the question is, what is it for this year? So you divide 300 over 1,000, and that is the incidence. Incidence is new cases, and the answer is 300 minus 200 over 1,000, which is 100. 100 over 1,000. The result is 0.1, and that's a descriptive study. Descriptive study. A descriptive study is, according to the book Dental Secrets, I'm gonna read point 46 of Dental Secrets. Compare cross-sectional, case control, and cohort studies. Cross-sectional studies are a type of descriptive epidemiologic study in which the exposure and disease stats of the population are determined at a given point. For example, the caries status of a U.S. adults aged 45 to 65 in the year 1992 may be determined by a national dental survey and examination. Case control and cohort studies are analytical epidemiologic studies. In case control studies, participants are selected on the basis of disease stats. The cases are persons who have the disease of interest, and the control group consists of persons similar to this case group except that they do not have the disease of interest. Information about exposure stats is then obtained from each group to assess whether an association exists between exposure and disease. We're going to see a little bit more about descriptive studies. In Board Busters says what descriptives. No, there's nothing about that. Let's see. So, a dentist reviewed an existing 1,000 charts. Noticed among these 1,000, last year 200 had a period, after 300 had periodontitis. After 300 have periodontitis. How much is the incidence? 0.1.